Today's title presentation, it's called Ketamine Infusion Therapy and Beyond. And it's Palm Springs Psychedelic Society. Thank you guys for being here. A few disclosures. I am going to be speaking about ketamine for off-label purposes. I'm also the founder and medical director of Reset Ketamine in Palm Springs, as well as a co-creator of ketaminestartup.com, which is an online course where I teach physicians and clinicians all about ketamine therapy and starting up practices. And remember, this presentation is not a substitute for medical advice. So an overview of today of what we're going to be covering. We're going to be talking briefly about the current state of mental health, about the psychedelic renaissance that is occurring. We're going to shift gears and talk about ketamine, history to what we're using it for. Then I'm going to share a bit about Reset Ketamine in the clinic, and then kind of looking ahead, like what options and therapeutics are available out there. And again, we'll finish with the Q&A at the very end. So what is the biggest problem that's facing society these days? As you're probably well aware, there's increasing rates of depression, anxiety, post-traumatic stress injury, also known as PTSD, and most importantly, suicide. This is all increasing over the years. And you may or may not know this already, but depression is the leading cause of disability worldwide. More than 300 million people are affected by depression. And overall, 1 in 5 people do have and are challenged by a mental health condition. So if it's not you yourself, it's someone in this room or a friend, a family member, someone close to you. One of the challenges is that these traditional medications that we use, SSRIs, antipsychotics, anxiety medications, sometimes they can take 2 to 3 months to kick in. And they come with a host of side effects. Weight gain, difficulty with sexual performance, anorgasmia, a host of side effects. And it takes a bit of time. So as a result of that, there's been an explosion of psychedelic research. Pete had mentioned, he's MAPS trained, and now they've rebranded themselves as Lykos Therapeutics. There's research happening at the Imperial College of London, Johns Hopkins, Harvard, UC Berkeley, NYU, Yale. So there's a lot of research that's occurring in this space. And I believe Alan had mentioned this earlier, that the recent FDA approval process for MDMA therapy, it's not official yet, but there was a vote by the advisory committee to the FDA where there was, I think, 10-1 saying, no, we're not in favor of recommending this for FDA approval. So it is a bit disappointing and challenging to hear. Absolutely. And there's many options that are out there, right? Maybe not all of it's available, but there's MDMA therapy, psilocybin therapy, LSD therapy, ibogaine, ayahuasca, 5-MeO, DMT. And what's nice is that there is increasing awareness about these options. But the biggest challenge today is that all of these substances are currently DEA Schedule 1, and they're not readily available for patients. I know some patients do have access to it, but it's not as easily available for many people. So I'm all about being here now. I actually have a tattoo here. This is be here now. Be here now, being present. So what is available and legal today? And that is ketamine therapy. So I want to tell you a little bit about the history of ketamine. It's an old drug, and it's a member of the arocyclohexylamine group. And for people who've taken organic chemistry, raise your hand if you've taken OChem. Way back in the days. So arrow referring to the benzyl group, cyclohexylamine. So this is a category of chemicals. And it actually started with an older drug, also known as phencyclidine. Phencyclidine was made in 1926. It was actually made by a pharmaceutical company, Park Davis Pharmaceuticals. And the reason they made phencyclidine was for use as a general anesthetic. However, it had a ton of side effects. So they would give the phencyclidine for general anesthesia, but then hours even after they had administered it, the patients were still experiencing these psychotic symptoms. And they discontinued it because of that reason. And then later it did become recreational drug of abuse. So it was made in underground labs. It was really popular probably in the 70s, 80s, known as angel dust or PCP. So when Park Davis Pharmaceuticals, they had this compound phencyclidine, they said, Well, we know it can work as a anesthetic, but what can we do to make it safer? And so they consulted with an organic chemist, Dr. Calvin Stevens, who was at Wayne State University. And they said, hey, we got this medication, phencyclidine. What can you do to make it safer? And so what he did was he took the original compound and made a bunch of derivatives. And one of those derivatives was called CI 581. CI stands for Clinical Investigation Drug 581. And if you notice in the chemical structure, for those people who recall, there's a ketone group at the bottom, right? And then there's an amine group, which is the nitrogen with the CH3. So that's how the name ketamine came in, a ketone group and an amine group. And then later it became called ketamine. Ketamine was first used in humans in 1964. So there was, once they had discovered, yes, it can be safe alternative, they actually tested it on volunteers. It was at a prison. They took inmates and they said, can you volunteer for this study? So 20 inmates volunteered for this study. Don't know about the IRB protocols back in the days, but regardless, they described these transient hallucinations, these dream-like effects, spaced out, floating. And the great part about it was at the highest doses, they did find that it induced profound anesthesia. And once it stopped, the effects rapidly faded. And that was nice because that phencyclidine didn't do that. And eventually they termed it a dissociative anesthetic. And if you think about the word dissociative, it's called dissociative because it's literally disconnecting the mind and body. And when that happens, then we're allowed to do the procedures for those patients, whether it's a shoulder dislocation or a little kid with a facial laceration. So by disconnecting it, creating an anesthetic-like effect, then we're able to do procedures. And so that's what Park Davis Pharmaceutical said. Hey, we got this drug. It's called ketamine. Can you approve it for use as a general anesthetic? And so it did become FDA approved in 1970. And specifically on label for surgical and diagnostic procedures. So since 1970, that was when the Vietnam War was going on, and it actually became the most widely used battlefield anesthetic. And it was nice because the medics could give it to their wounded soldier, boom, maybe an intramuscular shot. And what's different about it is it does not cause as much respiratory depression as opioids. So morphine was commonly used as a pain medicine back then. And what it allowed them to do was give the shot of this ketamine to their fellow combat personnel and then safely transport them to the main hospital. So for 20 years, it was used from 1970 until 1990, mainly in the operating, until a landmark study came out in 1990. And they said, hey, not only can you use it in the operating room, but you can actually use it in the emergency room. And so this study was published in Annals of Emergency Medicine, and they were looking at pediatric population, specifically, hey, how safe is this ketamine drug for use? And they said, yes, it's very safe. And what's interesting about this study is it was done at Loma Linda University, which, as some of you may know, it's about maybe an hour away from the bus. And that's where I did my residency training. So now ketamine has been used safely in humans for over 50 years. So 1970 FDA approved, it's 2024. So that's 74 years, or excuse me, 54 years of use. And it is also on the World Health Organization's list of essential medicines. These are medications that any healthcare system needs to have to be most effective. Now, after the use in the operating room and then the emergency room, then some doctors and psychologists and psychiatrists said, this is a really fascinating drug because some of the patients after their anesthesia procedures, they were noticing like, I feel better. My mood has been lifted. So Dr. Berman out of Yale, he did a study in about 2000. And this is when this article was published, where they took, I think about 10 patients. So it was a very small sample size, gave them IV ketamine versus a placebo, so saline. And they said, hey, let's see the change in their depression scores. And in that study, 24 years ago, they said, wow, this can rapidly reduce depression. And so that was the first study. And since then, multiple studies have been published. And as you may know, so you have the gold standard, which is the randomized placebo-controlled trial. And then we take a bunch of those studies and put them into something called meta-analyses and systematic reviews. So Most recently, there was a systematic review and meta-analysis taking all of these smaller studies and saying, hey, can this be effective for treatment-resistant depression? And yes, they did find that it can be quite robust and significantly improve patients' symptoms. In addition to depression, they continued doing more studies, specifically looking at PTSD, also known as post-traumatic stress injury. So this is, again, a randomized, placebo-controlled, double-blinded study. And in this study, they used ketamine versus midazolam. And midazolam is a benzodiazepine. So it's not just saline, but something active. So the patient does feel something. And in this study, they found, yes, it can also reduce their PTSD symptoms. In addition to that, this is a study done from in Australia by Dr. Glue, and they were looking at ketamine therapy for use in anxiety disorders. So severe anxiety patients who've tried XYZ medications, not effective. And what they found was that, yes, it can also reduce anxiety as well. Another study looking at ketamine for suicidal thoughts. I had mentioned the rates are increasing dramatically. Can we use ketamine therapy for suicidal ideation? And in this study, they found that yes, it does cause a rapid reduction in suicidal thoughts associated with major depression. And again, these are randomized placebo-controlled studies. So now to this point, there's been more than 140 clinical studies looking at ketamine as various treatment options for mental health conditions. So how is this medicine working? How is ketamine working? I think of it as four mechanisms of action. So we're going to touch upon each of these. So we have the biological, and biologically, ketamine works on the NMDA, N-methyl D-aspartate receptor in the brain, and it affects a neurotransmitter called glutamate. And by blocking activity of glutamate on that receptor, it leads to a cascade of effects in the cells, leading to increased BDNF, brain-derived neurotrophic factor, which in turn leads to neuroplasticity and synaptogenesis, so increasing connections between synapses. Next, there's the functional mechanism. So this is really interesting because we have a portion of our brain, it's called the default mode network. And the default mode network is the part of the brain that's kind of active when we're not really doing anything. Maybe we're just daydreaming, just chilling out. And some people think that that's where kind of these ruminative thoughts live, maybe even the ego resides. Ketamine seems to disrupt activity of the default mode network temporarily while they're getting it. And so when that default mode network is shut down, it comes back. It's almost like a reset, where they're able to put in new stories and ideas into that default mode. Next, there's a psychological mechanism. So this is where ketamine, what I've seen is it seems to dissolve the layer between the conscious and the unconscious mind. And from, if you've taken psychology courses, you may have noticed like there's that iceberg metaphor where if you see an iceberg out in the ocean, all you're seeing is just that little top layer, and underneath is really the vast majority of the iceberg. It's kind of like the conscious and unconscious mind. What we're seeing is just the top of it. But what I've noticed is that ketamine seems to allow the patients to go into the basement of the mind, kind of explore like what's really going on underneath the hood. And they may get insights, they may get memories, they may get different emotions that come up during the session. Next is a spiritual. So this one is not as evidence-based, but, I think that I know with Brian, I was checking out your website, the biopsychosocial spiritual. I think that there is a spiritual component to the human being. And ketamine can potentially impact that spiritual side. But studying neurons to understand consciousness is like studying letters to understand Shakespeare. And what I mean by that is ketamine can create hallucinations, right? These experiences, I call them non-ordinary states of consciousness, and they may not be a side effect. So some of the experiences that someone can have, we'll start with the first one, an empathogenic experience. Awareness of the body, more empathy, more comfortable, more relaxed, reduced ego defenses, feeling of warmth, love, peace, euphoria, some visual effects, kind of like a screensaver. Next, you have an out-of-body experience. So this is where there's a separation from one's body, significantly diminished ego defenses, maybe even visits to mythological realms, encounters with non-terrestrial beings, dreams, re-experiencing the birth process. And then third, we have the near-death experience, where some people do state, yeah, it feels like I died. I had a complete departure from my body. My ego completely dissolved. And it almost feels like they're dying psychologically, or even being like a single point of consciousness aware of itself. Finally, you have the ego dissolving transcendental EDT experience, where it's a complete ecstatic state of dissolution, separation of one's body and soul, transcending normal space, time, mass, continuum, feelings of connectedness with the universal and consciousness, God, sacredness, something spiritual. And these are 4 types of possible ketamine experiences described by Eli Kolb, who's did a ton of research in this space. I want to shift gears and tell you more about Reset Ketamine specifically. So, a little bit about us. We got our team here, and shout out to my wife, Kim, who actually made all of these slides. As well as our team. We got our nurses, we got our medical assistants, we got a Nick here. And so this is our team. We do IV ketamine therapy. That's our specialty. And we do a holistic approach. I know several of you have mentioned the kind of a holistic picture. And that's really our approach to patients with that scientific allopathic approach as well. One of the important things with ketamine, it is a general anesthetic. That's what it's FDA approved for. So we do continuous vital sign monitoring. So some of you are nurses here. So we're going to measure the O2 level, the cardiac rhythm, the blood pressure, the respiratory rate, making sure it's safe throughout the entire infusion, which lasts roughly 40 minutes or so, although we do give them 15 to 20 minutes recovery time. But regardless, they're always monitored. It's very safe. And there's always someone with them present in the room. They're never left alone, whether it's me, nurse, medical assistant, like someone is always with them, because it can be intense sometimes. I do want to touch upon the biopsychosocial spiritual model, and some of you may be familiar with this. I went to med school in University of Rochester, where the biopsychosocial model was founded by Dr. Engel. But there's a 4th layer, the spiritual. So I'm going to touch upon each of these. So you have the biology of the humans. These are referring to like the subatomic particles, atoms, molecules, cells, DNA, epigenetics, so really the biology as we know. Next, you have the psychological component, the mind, the conscious mind, the unconscious mind, the life experiences, their behaviors. And then we have the social component of health, which refers to like relationships, to myself, to my partner, to my community, to my friends, to my family, to society, to earth. And finally, the spiritual component, the relationship of what beyond what we are, maybe what transcends this body. In addition to the BPSS approach at our clinic, we really pay attention to the set and the setting. So some of you may be familiar with that term, but this is a quote from Tim Leary. And he says, of course, the drug dose does not produce the transcendent experience. It merely acts as the chemical key. It opens the mind, frees the nervous system of its ordinary patterns and structures. The nature of the experience depends almost entirely on the set and the setting. At our clinic, we have 4 phases of ketamine therapy. So I'm going to touch upon each one of those. First, there's preparation. So 5 days before the actual infusion, we recommend 13 guidelines that the patients follow. Some of those include yoga, breathing, meditation, journaling, avoiding news, social media, anything that's going to not produce that positive impact for them prior. Next is the intention. Before every infusion, we ask the patient, what is your intention? What is your goal? What are you hoping to achieve? And having the patient focus on that throughout the infusion. Because as I mentioned earlier, ketamine creates new neurons, new synaptic connections, and what the person is thinking about and focusing on will impact their experience. The third phase is the experience, so the experiential component. And this is where the patients come into the infusion room. We have eye shades, a special therapeutic playlist, binaural beats, theta waves, chakras 1 through 7. So the music will also play a key role. And finally, the integration piece. And that is where, if I had to distill down what integration means to me, it's kind of like doing homework, right? So what did I gain from that ketamine experience? And what do I need to do now? What action do I need to take? It may look like talking with their psychologist, their therapist, yoga, meditating, breathing exercises, journaling, making art, playing the piano. So taking the experience and distilling it down into some actionable form that they can take home. We also tailor the dose to each patient. Some people are really sensitive. Some people are very tolerant to ketamine. And the studies show that the more dissociation one has during the experience, the more improvement in their symptoms. So our goal, we try to just gently titrate the dose. And that's the nice thing about IV is I can know exactly down to the milligram how much we're giving. It's 100% bioavailable. So we can make it very specific to that patient. So what I've noticed is that there's kind of a Goldilocks amount where it might be zero point 0.4 milligrams per kilogram or 0.75 milligrams per kilogram. And each time we're weighing them, getting the accurate dosing just to custom tailor, find that Goldilocks amount. And we want one that's like not too hot, not too cold, but just right in the middle. And again, every patient is going to have a different dose. As far as scheduling, the initial studies, they were doing 6 infusions. So the first one was they were doing it like Monday, Wednesday, Friday for 2 weeks. So that's the 6 series. Other studies have shown that you can do actually 2 times a week for 3 weeks. Again, that's 6-phase protocol. I kind of think of ketamine as the initiation phase, so those initial 6 sessions, followed by maintenance as needed, which might be a booster once every 1 to 3 months for improvement and maintenance of their symptoms. And so that's all I want to say about ketamine. I'm going to be answering questions about it later. But now I want to look ahead. So one of the things that I've been really fascinated about is something called stellate ganglion blocks. This is not a psychedelic. This is an old procedure. It was actually started in 1924. They were using it for complex regional pain syndrome, as well as refractory ventricular tachycardia, VFib. And what now they're finding is, well, let me tell you a little bit about it first. So the stellate ganglion, it's an outpatient procedure. We do it at the clinic under ultrasound guidance. We go into the neck and we visualize exactly where the stellate ganglion is. And as you can imagine, there's some pretty important structures here. Got the internal carotid artery, the jugular vein, you got the cranial, cervical roots, vertebral artery. So it's a very delicate procedure. But using the ultrasound machine, we go in and identify the C6 and C4, cervical spine 6 and 4 levels, inject a medicine called ropivacaine and dexamethasone. So that's a steroid and an anesthetic. Lasts about 6 hours. So we go in, find the exact location, numb it up. It kind of puts the nervous system to sleep for about 6 hours. It's like letting it take a nap, or if you're at the house and you need to turn off this on and off the circuit breaker. It's kind of shutting it off for about 6 hours. When it wakes up, it's less hypervigilant. It's less on alert. And it's not solo monotherapy, but I really view it as an adjunct to other methods, whether it's ketamine therapy, meditation, yoga, acupuncture. So it's one tool, another tool that we have in the arsenal, specifically for post-traumatic stress disorder. And here's some recent studies that were published. So the first one, this was actually from the military, where they were using SGBs to treat PTSD, PTSI, in 166 patients. In that study, they found 70% of patients 3 months out, 6 months out had significant drops in their PTSI scores. There's a randomized placebo-controlled trial published in JAMA Psychiatry, which also looked at the effectiveness of SGBs. There's also some studies showing that if a person doesn't respond to the right-sided SGBs, then you want to do the left side, because it's almost like a right-hand, left-hand dominance, where the stellate ganglion actually lives on the opposite side. And then if you notice that these top 3 studies are looking mainly at the military population, well, there was a 4th study done looking at PTSI from all sorts of different populations and groups. So there's 3 take-home points that I want you to go home with, okay? Number 1, psychedelics can potentially be transformative for mood disorders, but not readily available for patients quite yet. So that is pending. Thus, what is available now? Well, ketamine therapy. We have it now. It's legal. It's safe. In particular, when we use it consciously with attention to preparation, intentions, setting, and integration. And then finally, the 3rd point is to become aware about this new procedure, stellate ganglion blocks, because it can really help reset the autonomic nervous system as an adjunct for PTSI symptoms. And with that, I will open it up to the Q&A. We have societal stories and narratives that get passed down. And so if someone has been told a story for many, many years, well, how do you change people's minds? And my answer to that as a scientist is, number 1, the scientific data. But sometimes, to be honest, that doesn't work either. So it's about stories, news stories. Yep, that's the old story. We got the new story. And I think creating new stories. And, there's a lot of documentaries. Pete had on Michael Pollan's Netflix documentary, How to Change Your Mind. So I think it's about recreating the narrative, but it does take time. And I'll give you one example of this. Back in the 1800s, there was a doctor named Igor Semmelweis. He was in Vienna. And what he was noticing was that women, during their deliveries, If they were delivered by a doctor, they would get childbed fever. They would get an infection. But what was interesting is in the 1800s, doctors were not washing their hands. So they would go from the anatomy lab where they were working with dead bodies, cadavers for, med school, and then they would go from there and deliver the moms. So Dr. Semmelweis noted, hey, maybe we should like wash our hands before we go deliver these moms. And he published the data and he said, hey, I took a group of doctors, I had them wash their hands. Turns out they had less rates of infection. And he was presenting it to the scientific medical population. And they're like, nope, you're wrong. We don't need to wash our hands. Doctors are gentlemen. Gentlemen, we always have clean hands. And so it took about 50 years from that knowledge to actually putting it into place. And now, of course, we're going to wash our hands before we do any procedure. But again, the medical community can be slow to change. And I think it's patience, education, and rewriting the narrative as well. I think it's about setting expectations. So I don't think of ketamine as a panacea. It's not going to cure everything. And it takes work, right? Because then they can have these experiences of non-ordinary states of consciousness. But if they don't do the homework post ketamine, then I notice they don't get as robust effects. So I think it's saying, yes, it's a tool, but it's one tool out of our arsenal of tools. I kind of think about health as like, let's say you're building a house, right? And so if I'm building a house, I'm going to need an electrician. I'm going to need a plumber. I'm going to need someone who can do drywall, someone who can paint. And for me, when I think of ketamine amongst these other tools, it's one of the tools in the arsenal. And explaining to the patient, kind of setting the expectations. Yes, it can be quite effective, but there's going to be work and it may not be effective in 100% of patients. So I think kind of letting them know in advance. And actually at my practice, a lot of times I'm kind of persuading patients to not do ketamine. It's not like, hey, you should get it. I'm like, well, if you have any doubts or reservations, hold off on it. Like, I totally get it. And take your time because this can be intense, right? And if someone has been wearing a cloak of depression or anxiety or PTSI for 20, 30, 40 years, it's hard to take off. And so I think a gradual process, setting expectations, and knowing that it's one tool in the arsenal can be really useful. As far as pharmaceuticals, the ones that decrease the effectiveness of ketamine would be lamotrigine, also known as Lamictal, which is typically used for bipolar disorder. And second are benzodiazepines. So categories of that include like Ativan, Xanax, Klonopin. What I've noticed and the studies have shown that those two pharmaceuticals decrease the effectiveness of ketamine in some patients. As far as recreational or not prescription would be, I've noticed the marijuana also decreases the effectiveness as well as alcohol. So, and I think the alcohol is specifically because of the pharmacology of it, where it's working on the GABA receptor and it's blocking activity from the ketamine on that receptor. So, oh yeah. So to answer the bottom line, it is if someone is taking these substances, they might titrate their dose of benzos slowly or lamotrigine in conjunction with their psychiatrist, or if they're on alcohol, marijuana, decrease that use significantly. And sometimes they're like, hey, I've been smoking pot for 30, 40 years. It's like, okay, well then maybe they need to get, acute rehab, inpatient rehab, especially for alcohol use. Cause then, if they've been drinking for quite a bit of time, they can get alcohol withdrawal symptoms and seizures. So it can be dangerous. So we just try to do it as safely as possible and say, hey, if someone is really suffering from a substance use disorder, get free from it for at least 30 days before you start. Ketamine can stimulate the heart. So if someone has a history of coronary artery disease, we'll say, hey, actually see your cardiologist, get a stress test before, right? So that's one example. If someone has active bipolar phase, then that might be another one where if they're already in a manic phase, then it could ramp them up and even, make that worse. If someone has a history of schizophrenia, so would be another contraindication where they're like, yeah, I've had schizophrenia. It could turn into a psychotic episode. So those are a few. But for every patient, I do a consultation and go over, hey, all of their meds, all of their past medical family, surgical, allergies, everything to make sure. And we do frequently say, no, you're not a candidate because of X, Y, and Z. Sorry. And, make sure you get the stress test done or make sure your potassium's adjusted or make sure, this is modified before we treat you. The set and setting play a huge role. So, for example, when I was in the ER, I was putting a chest tube, excuse me, I was putting a chest tube. I don't know if you guys are familiar with that. Patient had a pneumothorax, and this was like, and I was giving ketamine, administering it all the time in the emergency room. So this guy, I'm doing the chest tube. He's in a lot of pain. I tell the nurse, hey, can you grab me 100 mgs of ketamine? And so he's already in pain. I pushed the ketamine, and this guy, after I pushed, and I pushed it pretty rapidly, he is screaming, he's thrashing, he's saying, I'm in hell, I'm seeing demons, Satan. And it was the most unpleasant experience for him because we didn't optimize it, right? He was already uncomfortable. And then, because we're putting tubes into his chest, and it just exacerbated it. So sometimes going to that dissociative, if they're not prepared for it, it can lead to really challenging experiences. IV racemic ketamine contains 2 isomers, an R-ketamine and an S-ketamine. So when Johnson & Johnson, which is a publicly traded company who wants to make profits, all good, they sell, wow, this is really effective. How can we patent this? And so what they did is they took one derivative of S-ketamine, and they said, let's make it, let's get it through the FDA approval process because we can make money for 20 years based on the patent. And they did get it FDA approved, but it's not as effective. I think you need S-ketamine and R-ketamine, and it costs like $1,000 per spray. So what happens is the insurance companies, they don't want to pay that because, it's $1,000 each time they have to do it. It's like 10 sprays in the first month. And so they're like, they really make the patients like show documentation. Oh, you have to show me that you failed your your antidepressant. As a matter of fact, give me the CVS receipt from 5 years ago. Prove that you actually filled it. So some insurance companies are really balking at paying for it. But for me, when I see the effectiveness of the patients and seeing the results, I'm like, it would save them money. Like it would save them an ECT, which is an inpatient hospitalization, costs probably 20 to 30 grand for inpatient stay. Like I think, because they are driven by the profit as part of their duty to shareholders. It's like, well, as an insurance company, it would actually save them more money in the long run.